One. Please start, sir. We are live.
Good evening, all the delegates and today's eminent faculty for Dr. Sunil Thanvi sir. This is about today we have. I would like to welcome for CLEARTalk meet. CLEARTalk is one more facet of Unite Against Dyslipidemia from Zydus Life Sciences, and a recent development in the field of dyslipidemia, that is bempedoic acid and clear outcomes trial, which was presented in ACC 2023. We have one of the best faculty to speak about this clear outcomes through the lenses of clear outcomes trial, bempedoic acid through the lenses of clear outcomes trial, Dr. Sunil Thanvi sir. Sir is a professor and head of the department cardiologist, senior interventional cardiologist in Zydus Hospital, Ahmedabad. Sir has won Glory of Gujarat Award in 2015. Sir is author, reviewer, clinical investigator. He is founder director, Brain Heart Foundation. Dr. Nathubai Patil Gold Medal in Cardiology from Gujarat University. Sir has experienced more than 35,000 procedures. He is faculty at various forums, national as well as international forums. Without wasting much of our time, I would like to hand over session to Dr. Sunil Thanvi sir. So over to you, sir. Thank you.
Yeah. Thank you, Satish, for a very kind introduction. And I think this is a very important time and a very good forum to talk about dyslipidemia and the challenges that we face on a day-to-day basis, because we know that with the glut of cardiovascular diseases that are now flooding our hospitals and our practices, patients getting younger, disease getting angrier and more diverse, more diffuse. It has become all the more important to actually control all the possible risk factors, and one of them being the lipid profile, the LDL to be more precise. Rather, I would say the oxidized LDL to be more precise. So right from beginning, we have had a lot of medications, a lot of drugs, and enough number of studies to tell us that as you go low on LDL, better are the outcomes. So today I'll be talking about this particular facet of a difficult dyslipidemia and the options that we have today and how best we can utilize the strategies with the given molecules that are there. Next slide. So as I was alluding to earlier, we all know that LDL-C lower is better and for longer time. I mean, as long as you can keep it under check, the progression of atherosclerosis is at a minimum. I cannot say it is zero because there is no study yet which has showed a level where you don't actually have a zero atherosclerosis. Yes, we have studies which have shown reversal of plaques. There are studies which have shown significant reduction in atherosclerosis, but to have a zero atherosclerosis is probably only possible in those who are genetically blessed, those who have a very strongly functioning HDL, like the pygmies of south of the African continent. So they are the only ones who are probably spared of the cardiovascular problems. But otherwise, everybody else, especially Indian and South Asians, are at a very high risk of developing not only cardiovascular but also cerebrovascular and peripheral vascular diseases. Atherosclerosis, mind you, is a vasculopathy. It involves the complete vascularity of the body, right from the brain to the toes. So cardiovascular disease or cardiovascular problems are just a tip of the iceberg. If a patient is having a cardiovascular issue, mind you, he would also be harboring atherosclerosis in various vascularities of his body. So be very careful when you are actually examining and assessing a patient or evaluating a patient of atherosclerotic cardiovascular disease. I dare say that if a patient comes to you with a peripheral vascular problem, be very sure that the patient could be having a cardiovascular issue along with it. No doubt about that, because peripheral vascular disease happens only when there has been a very rampant and a very diffuse atherosclerosis, by which time the heart vessels would have got involved. So, so there have been various molecules, as you can see, fibrates, niacins, statins. Then we have bile acid sequestrants, we have ezetimibe. We have the CETP inhibitors, which are used for HDL, but however, didn't really work. but they not have really, helped us in getting the LDL to a level where we can call the patient to be, free of atherosclerotic dilemma. Then we had various surgeries like little bypasses, which also was postulated to reduce the cholesterol absorption and therefore reduce the LDL in the patients and future atherosclerotic event, but it didn't really work out that well. Then came in the PCSK9 inhibitors, which have proven dramatic reductions in LDL and in the event rates. But the prohibitive cost of this therapy, not only in India, but even in US and Europe, has actually limited its use and its potential vastly. Next slide. We also know that each 1 millimole per liter reduction of LDL gives more cardiovascular reduction according to number of years in trials and comorbid conditions as well. So if you have, if the patient has been, more than 6 years into the LDL reduction, then probably the overall reduction risk is 3 times more as compared to a patient who has just been on statin for a year or so. So the idea that the patient should have, an initial reduction and then can be on a placebo dose of statin doesn't really hold. When we talk about a patient with atherosclerotic cardiovascular disease established, the patient has to be on high intensity statin lifelong. That is what the recommendation says. And if the patient doesn't have an established disease, but is at risk for atherosclerotic diseases, for example, is a diabetic, smoker, obese, hypertensive patient, then at least the patient should be on a moderate intensity statin therapy. So the idea is that longer that the patients remain on these therapies and the longer the LDL remains below the permissible limits, better it is for the patient outcome. Next. Management of dyslipidemia is high on priority because even the Interheart study told us that of the 9 risk factors which were evaluated and which proved detrimental to the occurrence of the first myocardial infarction, it was LDL or lipids to be more precise, which were the number 1 culprit for development of the cardiovascular event. Therefore, it becomes very important to control dyslipidemia and to control LDL, oxidative LDL especially. But what are the main various concerns? Do all statin users achieve LDL goals as per current recommendations? And if not, then how to achieve LDL target after maximally tolerated dose of statin? Even after giving, see, the catch point is maximally tolerated because not all patients are going to tolerate statins to 80 milligram or 40 milligrams. Some of them would start having symptoms, muscular symptoms or transaminase rises even after 10 to 20 milligram. What then? What next? How to then control the LDL in that group of patients? So the first concern that do all statin users achieve LDL goals as per guidance recommendations? No. If you look at the LDL targets, which wasn't defined by the Lipid Association of India in 2020, you can see very clearly that they have said that the patients can be divided into low risk, moderate risk, high risk, very high risk, and extreme risk. Now, who are the patients at extreme risk? There are 2 sort of patients. One, patients who have had repeat events in spite of having undergone angioplasty or bypass surgeries, or in spite of being on maximally tolerated statin therapies, still the patient keeps on having events. That is category B, and category A is CAD in more than one feature of a high risk subgroup, which means more than 3 major risk factors or with more than one and other conventional risk factors that account for this. Next slide. So if you look at the revised LDL-C target for our Indian population, we are looking at low risk, the LDL has to be less than 100. Moderate risk, it has to be less than 100. But when it comes to high risk, it has to be less than 70. Very high risk, it goes down to less than 50. And extreme high risk, category B, which means the patient keeps on having repeat even in spite of therapy, in spite of interventions, the LDL targets are actually supposed to be less than 30. So that are the treatment goals. They say that drug therapy should be considered if the LDL keeps on remaining above 30 in patients who are receiving therapies for dyslipidemia. So we have to understand very clearly that when you talk about LDL levels of 100, and we feel that the patient will remain event-free it is actually a very futile thought. We have to risk stratify the patients, we have to categorize the patients, and then decide at what level of LDL the patient should be on and what therapy the patient should receive to achieve that LDL goal. Next. So these are European Society guidelines. As you go high in the risk, more reduction of LDL is what they require. At low risk, 16 and 19, they both said that LDL of 115 was okay. When the risk increased to moderate, it went down to 100. With high risk, it went down to 70. And with very high risk, they said very clearly that the LDL levels have to be less than 55. While in Indian patients, we say it has to be less than 50. Extreme risk, it has to be less than 30. So that is what we're looking at right now. So very high risk would include definitely patients who undergone interventions. So all patients undergoing interventions, the LDL levels have to be 55 or less than that, mind you. Next slide. Of the revised guidelines, how many patients do actually have a controlled LDL-C? If you look at this European study, a Da Vinci study, which was studied on about 6,000 odd patients, wherein they had about equal distribution of primary and secondary prevention, they found out, next slide, that as per revised guideline, only 27.6% eligible patients were receiving high intensity statins, and only 30% patients achieved lipid goals with high intensity statins. So this is what we're talking about the European continent, where everywhere they are supposed to talk about protocol driven therapies. In India, where there are no protocols, where there are no regulations, where nobody cares about what's going on to the patient, the numbers would be dismally low. I dare say less than 10% of the patient would actually be receiving, reaching the goals that we're looking at. Next slide. In very high risk patients, the Da Vinci study said that nearly 37.5% of patients were receiving high intensity statins. However, only 22% patients achieved lipid goal with high intensity statins. So again, a dismal number, by looking at the risk that the patients were and the numbers that they achieved at the end of the study. Next. So that is the first thing, that in spite of the recommendations, in spite of a large body of evidence which says that the LDL levels have to be pretty low, we don't really see it in the real world scenario. Second concern was how to achieve LDL targets despite maximum dose of statins. Next slide. So when you talk about maximally tolerated statins, we are talking about patients who would be on a diverse dosing. Somebody could tolerate 40 milligram of statin forever. Somebody would not be able to tolerate even 20 milligram and would start developing muscular symptoms, would start developing SGPT, SGOT rises, would start developing myoglobin So this is a diverse group of patients that we see in our practice. And so we have to be very individual when we're looking at patients. First and foremost, we have to first define whether this is actually a statin-induced side effect. That is very, very important, because statin-induced muscular symptoms are very commonly thrown about. But if you actually investigate into it, very few numbers are due to statins. There could be other causes, like the patient could be having low vitamin levels, the patient could be having low TSHs, they could be harboring arthritis. There could be so many other reasons for the patients having joint pains, muscular pains, so on and so forth. Uncontrolled diabetes could also be leading to calf pains and muscular pain. So we should not jump to a conclusion when the patient comes to you with muscular symptoms saying that this is definitely a statin-induced musculopathy. We need to investigate in terms of, say, you can go for a CPK total, you can look for myoglobinuria, you can try to change the dose of statin and see if the patient's improved. You can maybe try to change the statin itself. If the patient is on etravoy, could change it to Rosuva or Pitava or whatever you feel like, or simvastatin, and see if the patients actually benefit with the change. If they don't, we know for sure that this is not a statin-induced thing. But if definitely the patients are having statin-induced problems, then what do we do? In patients of atherosclerotic cardiovascular disease, check the baseline LDL levels. If the patients receive only statin, the reduction would be about high intensity statin, the reduction would be about 50%. If the patients are put on a fixed dose combination of high intensity statin with ezetimibe, the reduction amounts to about 65%. If the combination is of high intensity statin with bempedoic acid, the reduction goes beyond to about 70%. a combination of high intensity statin with bempedoic acid and ezetimibe gets the LDL levels down by 75%. And a combination of ezetimibe with PCSK9 inhibitor with a hydrostatin gets LDL levels down by 85%. So this is what we are looking at when we are trying to treat patients who are either statin intolerant or in spite of maximum tolerance therapy cannot get the levels down. What happens with patients having hypercholesterolemia? If you just give statins, naturally they don't work. So we have to give them along with ezetimibe, and there the high intensity statin ezetimibe gets the levels down by about 65%. High intensity statin with bempedoic acid gets it down by about 70%. A combination of statin, high intensity statin, bempedoic acid, and ezetimibe gets it down by 75%. But if you are adding bempedoic acid, ezetimibe, PCSK9, and high intensity statin, it goes by more than 85%. So a polytherapy addition of various molecules, either stepwise or together, definitely helps in competing the challenge that this particular scenario throws. If the patient has complete statin intolerance, then what to do? Then the patient would have to be on a combination therapy of either bempedoic acid or bempedoic acid with ezetimibe, wherein the reduction could be close to 40%. PCSK9 alone would lead to a reduction of about 60%. A combination of ezetimibe and PCSK9 would lead to a reduction of about 70%. And a triple combination of bempedoic acid, ezetimibe, and PCSK9 would lead to a reduction of about 85%, 80 to 85% or more. So in a nutshell, if the patient is of atherosclerotic cardiovascular disease and does not have familial hypercholesterolemia and does not have complete statin intolerance, probably addition of these molecules does help. And we normally tend to go stepwise. We first add ezetimibe, doesn't work. We add bempedoic acid, still doesn't work. Then maybe PCSK9 would be the way to go. In familial hypercholesterolemia, when nothing works, LDL apheresis, liver transplantation, these are all methods that can help in reducing the LDL levels in this group of patients. Next. High intensity studies has low adherence, which leads to higher MACE event rate. So that is again a problem because there are various studies which have shown that nearly 66% patients presenting with ACS did not actually take high intensity statins after discharge. They were either on 10 or 20 milligrams because of either physician inertia, fear of side effects, patients not willing to go up on high dose, whatever the reasons, but nearly 66% were not of high intensity statin, and nearly 50% of patients had drug interruption or end of therapy within the first month of the index event. Again, fear of side effects, unjustified stoppage of statins because of musculoskeletal symptoms, physician inertia, call it whatever you say, but this was associated with a reduction in survival and increase in mortality by nearly 16%, p-value being significant by less than 0.001. So the point is that patients have to be on high intensity statin therapy, maximally tolerated, to get a reduction of at least 50% LDL or more from baseline. Once you have achieved that, you need to achieve the target LDL that we're looking at the particular risk. The patient is at low risk, moderate risk, high, very high, or extreme high risk. Depending on the risk level, the target levels have to be achieved either alone or in combination with various molecules. Next. So therein comes the molecule of today, that is the bempedoic acid, which is an ATP cited lyase inhibitor, a first-in-class LDL-lowering drug, a first non-statin therapy, which has shown to be beneficial in both reducing LDL and reducing the cardiovascular event rates. Approved indications as of today are to reduce uncontrolled LDL levels with maximum tolerated statin dose. Again, remember the catchword is maximum tolerated. We are not saying that you should reduce the statin dose and add bempedoic acid. We are saying patient should first receive a statin dose which he can tolerate maximally, whether it's 10, 20, 40, or 80. In spite of that, LDL doesn't come down, then you can add bempedoic acid. In patients with mixed dyslipidemia, familial hypercholesterolemia, and of course, extreme high risk or very high risk ASFD patients is where we can actually add bempedoic acid. Statin intolerance or whom statin is contraindicated or cannot be given are definite patients where bempedoic acid should be given and the patients would benefit out of it. The dose is 180 milligram orally with or without food. Fortunately, there is no interaction with food unlike other statins where you need to give it, 1 hour after food or 2 hours before meals. There have been, ever since the molecule has come into picture, various agencies have taken up very favorably. In fact, way back in February 20, it was first approved by US FDA. In March, the European Medicine Agency came into picture and it approved the therapy. The Lipid Association of India recommended the molecule as late as August 22. In October, the American College of Cardiology recommended the therapy. March 23 came the Clear Outcomes COT trial, which showed that addition of bempetic acid or even a low definitely gave us cardiovascular benefits. And in April 23, the the lipid expert panel approved the use of bempetic acid in patients who were either statin intolerant or could not take statin therapy to the maximum. Next slide. So what is bempetic acid? It's a novel, it has a novel mode of action. It inhibits the ACL enzyme upstream to the HMG-CoA reductase, and therefore that is how it acts on reducing the LDL while not acting on skeletal muscles because it is not a part of it. So it has no musculoskeletal symptoms to speak of, and therefore it is a very safe, at the same time efficacious molecule that can be used in patients with dyslipidemia. Next. What are the red flags and what are the green flags when the patient is on bempedoic therapy? The green flags are definitely renal impairment, no dose adjustment, hepatic impairment, no dose adjustment that is required. Yellow flags, all patients, we have to assess the serum uric acid when clinically indicated. And if there is history of gout, we need to keep a close watch at the increase in gout or the increase in hyperuricemia. Patients more than 60 taking steroids or fluoroquinolones with renal failure and history of tendon rupture, we need to warn the patient of a potential of tendon rupture or worsening of tendon ruptures. And we need to keep a very close watch on the patients and be very alert to signs of tendinitis or tendon ruptures that could happen because of therapy. Of course, patients who are 65 years of age taking steroids or fluoroquinolones and with renal failure and is a tendon rupture, we need to, and has a tendon rupture, definitely we need to discontinue if the rupture occurs and consider discontinuing if there's joint pain, swelling, or even inflammation in this group of patients. If the patient is taking simvastatin or pravastatin, again, the molecule is contraindicated because the natural statins, they increase the levels of the bempedoic actually increases the level of statins, and therefore they may cause side effects. Pregnant and breastfeeding females, as with other new molecules, have been out of study, and therefore we really cannot recommend giving them in this group of patients. The half-life is nearly 21 hours, so once a day dosing is enough. 70% excretion of total dose is through the kidneys. Therefore, when there is nearly 5% excretion to feces, less than 2% excretion unchanged drug through kidneys. However, as we have clearly seen, that in patients with renal impairment, no adjustment is necessary. However, it is not a study in end-stage renal disease, and therefore we cannot say whether in dialysis patients or end-stage kidney disease patients it will be safe or not. Next. The CLEAR outcome trial, which was a late-breaking clinical trial in the ACC 2023, presented by Steve Nissen, showed very elegantly. Next slide. That okay, it was the study was done in basically statin intolerant patients, wherein they had a 4-week run-in period, treated with placebo, and then they were divided into 2 groups. One was a group of placebo, one was a bempedoic acid, and then they were looked at the various outcomes, the primary and secondary outcomes that were seen. And the patients taken were all patients on secondary and primary secondary prevention with elevated LDL and statin intolerance. Next slide. So the background of the study was statin intolerance, which is seen in nearly 15% patients, and it prevents patients from achieving LDL levels and cardiovascular benefits. The background was use of bempedoic acid, which is a ATP citrate lyase inhibitor, which has a new mode of action, which bypasses the muscles and therefore could be beneficial and with minimum side effects. However, the CV outcomes were not assessed till date, and therefore this trial was done to see if the patients can be used along with lowering of LDL in patients with atherosclerotic cardiovascular disease to give them cardiovascular benefits too. Next slide. The primary and secondary endpoints were non-fatal MI, non-fatal stroke, coronary vascularization, and cardiovascular death. And of course, hierarchical testing of secondary key points were done. They looked at 3-point MACE, cardiovascular death, all-cause mortality, coronary restrictions, so on and so forth. Next. Next. So the demographic data were almost similar for both the patients who were in placebo arm and in the bempedoic acid arm. Nothing really to write home about. But you can see that an equal number of patients were on secondary and primary prevention. There were patients who had cerebrovascular diseases, peripheral vascular diseases, and coronary diseases. So all the vascular trees were there in the study, and they were looked into very minutely. Next. The primary result they showed that the 4-point MACE reduction was to the tune of 13%, 3-point MACE to the tune of 15%, fatal non-fatal MIs came down about 23%, and the rate of coronary vascularization came down by about 19%. As you can see that the graph diverges slightly late. However, once it starts diverging, the divergence continues, and therefore the patients keep on getting the benefit of the molecule as the patient keeps on receiving the therapy for his LDL, for his dyslipidemia, and for his cardiovascular diseases. Next. Effect of this regime on cardiovascular events among statin intolerant patients. Treatment with bempedoic acid was associated with low risk of 4-component MACE, 3-component MACE, MIs, and coronary vascularization, as we saw in the. It also showed a 21.7% reduction in LDL-C levels. As you can see very clearly, that the graph diverges beyond, as the time goes by, beyond 48 months, the graph diverges further. So longer that the patient remains on therapy, the better probably it is that the patient benefits. Not only LDL-C, even the hsCRP levels came down by nearly 22 to 25% in these patients who were on bempedoic acid, and therefore the event rates came down because hsCRP is a marker of inflammation and event rates. Lower the hsCRP, lower the inflammation, lower the event rates. So it not only reduces the LDL, but also reduces the inflammation and thereby helps in reducing the event rates in this group of patients. Next. Safety-wise, if you look at the serious event rates, it was almost similar to the placebo arm. Of course, there was just one concern that was for hyperuricemia and tendon ruptures that came in. Discontinued myalgia was actually similar. Diabetes was almost same. Renal impairment was almost same. So nothing really to write home about. It was almost similar to the placebo, and therefore it was found to be pretty safe. Next. So the conclusion of the study was that bempedoic acid becomes the first ACL inhibitor and the first oral non-statin to demonstrate statistically significant reduction in 4-point MACE and various event rates in patients with in patients with ASCVD or who had high risk of cardiovascular diseases with documented statin intolerance and an elevated LDL cholesterol level. So to conclude, we can very safely say that bempedoic acid is an effective alternative for statin intolerant patients, as the CLEAR outcomes very clearly showed that it is well tolerated. The LDL-C and hsCRP levels were reduced drastically. The primary and secondary endpoints were achieved in the trials. And of course, we can say that it is an effective approach to reduce major cardiovascular events in patients who are statin intolerant, cannot take statin therapy, have contraindication of statin therapy, or have to cut down the dose of statin therapy because of the side effects. Next slide. Yeah. Thank you for a very patient listening, and now we are open for questions.
Thank you so much, sir. Such a wonderful position to the point, and this was a very lucid presentation. There are a few questions which have come in chat box, so I would like to ask one by one. Initially, you mentioned about ESC 2019 guidelines. There's one question is how one can go low about LDL cholesterol. So how low can it can be, or whether it will lead to any neurological complications.
So yeah, so that's a good question because initially there have been trials which have shown probably when the LDLs go too low, there are issues with cognitive function, there are issues with the neural lining, and therefore the patient's dementia and Alzheimer probably increases. But however, That was just one single trial. And ever since, all the trials have shown it to be very safe. In fact, now it has been shown to be beneficial in patients with Alzheimer's by reducing the microvascular cerebral circulation and thereby improving the overall efficacy of the brain. So as far as the neurological outcomes are concerned, we're not really worried about that. How low can we go? Already we are touching 30. Whether we can go to zero or not, I'm not very sure. But even at 30, see, as cardiologists now, we are regularly keeping our LDL patient, the LDL of our patients around, say, 40 to 50 in general. None of our patients would be beyond 60 or 70 in any case. And we have found it to be very safe. None of the patients come to us complaining of any significant side effects to warrant stopping as a very safe therapy in that sense.
Thank you, sir. There's one question: is diabetic patient who is on statin conceived confirmed pregnancy at 10th week of pregnancy, and then so what are the adverse effects in pregnancy or fetus?
Adverse effects of dyslipidemia or diabetes on fetus? I couldn't get the point. See, on the fetus.
Actually, this is about a patient who is a diabetic patient and on statins.
On
and
statins, the side effect of statins is what probably they want to ask. See, to be very honest, when you're doing a clinical trial, the standard exclusion criteria involves pregnant females, lactating females, and therefore, in fact, a very strict contraception is advised in females who are undergoing clinical trials. So we really don't have any long-term data to show that the therapy is safe or unsafe. However, real-world data, wherein the females would be on statins for hypercholesterolemia, getting pregnant, containing statins, we have not really found any significant increases in any neonatal toxicities or any issues as far as the cognitive function of the babies or the neurological development of babies is concerned. On the other end, if the patient is on statins for a polyvascular disease, probably stopping statins would be detrimental to the overall outcome because, if the placental flow goes down, there could be issues with the development of the baby also. So it's a double-edged sword. We need to keep our clinical acumen. We need to keep a close watch on the LDL, on the fetal development, on the various parameters, and then take a call as to whether you want to continue or whether discontinue the medication to that effect. But as of today, there are no clear guidelines to say whether you should not give or give. But because they're not a part of trial, therefore, probably the standard recommendation is to stop it.
This next question is: at what age or at what level of LDL level we start statins in congenital dyslipidemia, as we are detecting high levels of LDL in adolescent age or in adults?
Yeah, so I think this is a very important question because with more and more children getting obese and lifestyle diseases affecting children at a very young age, hypertension and dyslipidemia and obesity and even diabetes is what we are seeing in a lot of children. And what tablets are intervening? Well, I will call them as a very low risk subgroup, right? Because they're not established atherosclerotic cardiovascular diseases. So we need to give a definite trial of intense physical activity and dietary modification to try and see if we can get their LDL levels down by lifestyle interventions. If we are not able to do it, and if the LDL levels are beyond 115, and if the child is obese, and if the family has a premature history of CAD, and probably I would see, I already have a 13-year-old boy who's on statins because his father has undergone angioplasty twice at the age of 40, right? So he's a very high risk subgroup anyway. So I put him on statins because his LDLs would remain beyond 150, 160, whatever we did. Again, it's a very individual thing that what we do when we look at children, because we need to look at a lot of things. And but yes, if the LDL are remaining consistently beyond 150, if there is evidence, you can do a carotid intima media scan and see if there's atherosclerosis over there. If it is there, then probably the patient has to be on statin. If it is not there, try to be as strict as possible with his diet and lifestyle, and try to see if you can get the LDLs to even to 110, 115 should be okay. I mean, we're not looking at LDLs less than 100 in this group of patients.
Thank you so much, sir. The next question is, when exactly one want to initiate bempedoic acid, and can it be used in ACS patients?
So ACS, we still don't have data. Secular outcomes have told us that there are cardiovascular benefits, but we still don't have trial data, a randomized controlled trial telling us that addition of bempedoic acid to statins or substituting bempedoic acid with to statins would give equal benefit in this group of patients. So ACS, definitely at this point of time, I would not recommend. When would I start? As I said, the patient is on maximally tolerated statin dose, not able to achieve LDL target. That is where I would put in bempedoic acid. I would first definitely try with ezetimibe because the pathway goes high intensity statin, maximum tolerated, not achieving, go to ezetimibe. Third is bempedoic acid, still not working, then we go to PCSK9. So first and foremost, risk stratify the patient, look at the LDL goal, look at the target LDL, look at what level of statin the patient is on. If it's just on a measly 10 or 5 milligrams, step it up and see if the patient can tolerate it. Still not achieving goal, add ezetimibe, still not achieving, add bempedoic acid. That is what is my put in practice.
So this is the last question on my screen. Is about patient. He's asking about, I'm having a diabetic patient. Any benefits of bempedoic acid in diabetes patients?
See, if you can achieve an LDL reduction, which is much more than a standard statin dose that the patient is on, I'll again put it as a maximally tolerated statin dose that the patient is on, then the LDL reduction itself is going to give us cardiovascular benefits. We all know that. So yes, addition of bempedoic acid in that way would give us benefits to that extent. Also, it reduces the hsCRP levels, and diabetic patients are more prone to inflammation and repeat cardiovascular events. So probably addition of bempedoic acid would be beneficial at that point also. But do we have an RCT saying that in diabetic patients, statin alone and statin bempedoic acid is better as far as the FC outcomes are concerned? No, we don't have it at this point of time. But common sense tells us that if it can reduce LDL better, if it can reduce hsCRP better, probably the patients would benefit much more as compared to patient being just on a maximum or a statin wherein you're not achieving the LDL target and not getting the inflammation right.
Indeed, it was a pleasure having you board on this evening, sir. And I would like to have your last comments and final comments for our audience to carry home.
Yeah. So as I said, what I mean to say is that we should not wish away statin just because we have new molecules. PCSK9 is a very powerful agent. It's one of the best agents that are there to get the statins down. We are not getting inclisiran, which is said to be a sort of a vaccine for dyslipidemia. But again, these are only prohibitive, medications. And being injectable therapies, again, there's a reluctance on the part of patient. There's a lot of non-compliance and other issues. So what is best for us? What is the real world strategy to tackle dyslipidemia? If the patient is not on a proper statin dose, escalate it to maximally tolerated statin dose. Still not achieving the LDL target, mind you, risk stratify the patient first, look at the targets, hike up the statins, not able to tolerate or not achieving the target, add ezetimibe, wait for a couple of weeks, still not achieving LDL target, or developing statin side effects, add bempedoic acid, or maybe you can remove statin if the patient is having statin side effects, and maybe add a combination of bempedoic acid with ezetimibe and see how things go on. And if it doesn't work, then of course we have PCSK9 inhibitors which would need to be given anyways, because otherwise the patient event rates are going to be so high that it would be detrimental to the health of the patient. And if it is a familial hyperlipidemia where nothing else is working, then probably LDL apheresis or even liver transplant to some extent does help in getting the lipids under control. And what is more important, as I said, I repeat again, is to risk stratify, to understand at what level of risk the patient is and what should be the target LDL level. And don't hesitate in achieving that and keeping the LDL level, because only when the patient remains at that LDL can you prevent the events. If the patient's LDL remains beyond 100, in high-risk patients, the patient is going to have repeat events come what may. So risk stratify, get a target LDL, try to achieve the target LDL by therapies that are available. And I think that is the best way to keep a patient out of the cardiologist chamber, as they say, and out of the the vicious cycle of interventions and surgeries.
It was nice having you on this evening talking about bempedoic acid and clear outcomes trials and clearing all our doubts. I would like to thank from Zydus Life Sciences. Would like to thank all the delegates who have joined and for their active presentation and asking questions. So thanks a lot, and please take care of yourself. Be safe. Thank you so much, sir. Once again, and thanks a lot. Bye bye. Take care.
Thank you, Sadish. Bye-bye.